So another way to use segmentation to help design appropriate interventions targeting high-need patients is to look at potentially modifiable spending across the segments. So we used ambulatory care-sensitive conditions here to define potentially modifiable spending. These are conditions like UTIs, dehydration, pneumonia. So these are conditions that are arguably developed by ARC that if you had good outpatient care and good coordination of care, you could have prevented these admissions from resulting in a hospitalization. So we added up all the dollars for ambulatory care sensitive conditions, and then we asked a simple question: what proportion of that spending is related to a segment, one of the 6 segments? So I'm just going to walk you to, there's going to be 2 bars, the proportion of the group of the segment related to the total population. So here, 9.7% of the relatively healthy make 9.7% of the population and spend 1.3% of potentially preventable spending related to acute care ambulatory conditions. The simple chronic make up 18% of the population, but they only spend about 2.6% of preventable dollars. And then I can show you the minor complex chronic, again, make a bigger proportion of the population, but only spend about 10% of preventable dollars. Major complex chronic and the under 65, the non-elderly disabled, they spend about equal proportions to their population. And the frail elders, even though they only make 8.6% of the population, they actually use almost half of all preventable dollars. So this is to show that modifiable costs are potentially concentrated among a small group of patients. And so I'm just going to show you one more slide related to this. So if you were to look at the potentially preventable spending by particular ambulatory care sensitive condition, you see here there's an example of 5 of these conditions. If you look at UTI, 60% of all dollars related to admissions of UTI are due to the frail elders. Dehydration, similarly, over half of all dollars spent on dehydration are by frail elders, and then pneumonia, a big proportion also by frail elders. On the other hand, for diabetes short-term complications, 61% of those dollars are driven by the non-elderly disabled. So how can you use this information? You can see that if you have a lot of frail elders, then programs around preventing UTIs, dehydration, preventing pneumonia, for example, like limiting the risk of aspiration, being up to date on vaccinations, for example, the pneumococcal vaccination, would be very beneficial in that group. As opposed to the non-elderly disabled, preventing complications related to diabetes is much more of a potential efficacious intervention.